Uh, Good afternoon to all of you. I welcome you all to this class, pathology class, today's afternoon session. But before that, I just want to tell you something today. See, there was a teacher who was probably taking or walking in a nice garden. Uh, so the teacher sees a young monk there. What was this young monk doing? So this young monk was just a teenager, and this teenager was teaching to about 5, 6 years older, the younger children. So this teacher got shocked. To become a teacher, oh, I've studied so much, I've taken degrees and all that. And what is this young monk teaching? And definitely, he could see the bright face in that young monk and all. So he goes near the monk and asks him, what is he teaching? He says, yeah, today is my first class. I taught them. Who are you? And he says, I am also a teacher. I also finished my first class. Then this teacher is curious to know what was he teaching. So he asked, what was your first class about? He said, this was about breathing. Oh, this teacher gets a shock. Breathing. We need to teach alphabets to children and words and all that. And what is this young monk doing with the children? Then the young monk, the teacher monk will say, he asked the teacher, what did you teach? He said, yeah, this was also my first class. So I taught them alphabets. And teacher is curious to know. So he'll ask, so why did you teach? uh, Talk to them about breathing, or why are you teaching? So the young monk replies, he says, see, breathing, or that breath is the one which stays with us from birth till death. Okay. See, he said, your friends may change. Your family also, your husband may change. You may divorce and get married, or whatever, and you may go to different place. You may not be here and all. Keeps on changing. But what doesn't change or never changes is the breath. Changes in the sense what stays with you, but definitely it changes. So when does it change? So for every emotion, the breath changes, right? So how does it? So when we are angry, how are we? That will show that. So when you're stressed, when we're anxious, that starts. Then when we have a sigh of relief after doing this, see everything. So he says this breath which stays with us is important. That's why whenever I teach a lot of things in pathology, I feel yes, microscopy and all that we teach to the students, but is it going to be helpful for them? Just to know, yes. Only if they become a pathologist, yes, it's important. Then they will learn again. So that's how each class, when anything has to be taught, that just keeps on repeating in mind. Whatever we are teaching, is it useful? So that's why I say affective domain. The attitude is very important, so that every child should start learning. So we have to be role models to teach them. Then only they can learn. So child learns from the mother by seeing mother what mother does. Mother says keep on doing, no. So it seems there was a board written uh, in front of a college where a very lot of traffic. They said don't park here. Rupees 250 is the fine that will be charged if you park. Do you think students will listen? No. Whatever boards are there, they were parking there only. So a clever teacher was there. So what he did was he changed the board, I believe. So parking rupees 250, he said. He changed. From then onwards, the students stopped parking there. So that means, how we have to tell the students that what they need and how we need to give also is very important. And yes, let me start with today's topic. Today is the last class about the last class on female genitals. There's something interesting to tell you at the end. Okay, so. Okay, what that interesting. Let me keep your curiosity till the end. So, what is this specimen? Can you see this? What is this? Uterus. Okay. So it is a cut open uterus that is mounted. So once we mount it, once we take it to the museum, it's very clear that there's something interesting there. So look at the uterine cavity there. Can you appreciate the uterine cavity? Yes. It appears slightly dilated. Okay. So look at the endometrium. Closer observation, endometrium is thick and it appears spongy. Also, there are some cystic spaces. Okay. This is what we have endometrium with lot of cystic spaces. The theoretical aspect is already taught to you by Dr. Disha. I'm just teaching you how to write a diagram. Okay, so be ready with your color pencils and whatever black and blue pencils you have and a paper. Just you have to click after you write, and then the images to be posted, emailed to your class assignment email. Okay, so go to the PPT. These two, the slide which I'm going to teach now, and another slide. So there, the slides that are given to you for discussion in the examination. So that's why it's like a repetition about the theoretical aspect, but practical is I'm just making you write the diagram so that you will learn about it. So the first slide here, what can you make out? This is again a cut section of the uterus. Okay, open. Can you make out this endometrial hyperplasia? It's looking like polypoid also, polyps projecting into the. So this is endometrial hyperplasia. Yeah. So this is a normal endometrium, how it is. So we have spoken about normal endometrium uh, at at length, enough. So what is the size, what is the thickness, and all that. So normally it is like this, but endometrial hyperplasia, see how it is increased in thickness. So what is the hormone responsible for proliferative phase? I've told you the different names of proliferative phase. Do you remember the diagrams you wrote? So it is estrogen. So estrogenic phase, proliferative phase. Then where is estrogen secreted from? Follicle. So we called it as follicular phase also. Yes. So endometrial hyperplasia. How do patients with endometrial hyperplasia present? So abnormal uterine bleeding. So whenever a patient presents with abnormal uterine bleeding, so this also is one of the cause we think the etiology. There's so many etiological factors. So we're calling this as abnormal uterine bleeding. Otherwise, it was called as dysfunctional uterine bleeding and all that. So and the terminology used to be removed after the etiology is identified. So otherwise, we can always say unexplained uterine bleeding till we find the cause for this. So why should we know about endometrial hyperplasia? Students may say exam point of view. So we have to know. You may see many of these, women suffering from endometrial hyperplasia. We should be recognize this. And this is one of the precursor of endometrial carcinoma. Again, we say this forms a fertile soil which endometrial carcinoma can grow. So, what are the features I just endometrial proliferative phase? You all remember? I think you had made a PPT for me and nice donuts you had shown. Proliferative phase, all tubular glands which were cut across and all that. So now that regular or that arrangement or such glands are lost. So they go on proliferating now. Why? Because of excess estrogen. So once they go on proliferating, so a lot of glands undergo cystic hyperplasia. There will be variation in the glandular side. So each gland grows at its own pace. So a lot of variation. That means it is excessive growth of the proliferation of the endometrium. Yes. So results from unopposed estrogen effect, we say. So there will be profuse and irregular uterine bleeding This could be seen in any time, and that is during reproductive age. But we say most frequent menopausal, postmenopausal, or premenopausal, and all that. But we have to remember this. Many patients come to us very late. So by the time they would have lost so much of blood that they would appear pale and come with iron deficiency. So any uterine bleeding which we consider abnormal, so which just disobeys the physiological bleeding, so that should be looked with attention, and everybody has to seek the advice of the gynecologist, obstetrician, or the gynecologist, or a physician. So etiology, it's a repetition, Dr. Disha has told. So prolonged stimulation of endometrium by estrogen. Why? Due to high levels of estrogen with diminution, or this is what I said, unopposed action of estrogen. So normally, follicular phase estrogen, then proliferative phase estrogen, then comes secretory phase, the progestational phase. So how the hormonal variation and all that. So then hyperestrogenic states. Remember, we were talking about functioning ovarian tumors last week. So you should list all the tumors that produce estrogen. Remember, don't forget, granulosa cell tumor, theca cell tumor. To this, what are the other tumors you can add? Serous tumor sometimes. Okay, important. But granulosa cell tumor, theca cell tumor are the most common that produce estrogen. All others may produce little amount of estrogen. Then obesity. This also we spoke in the last class. Peripheral conversion of estrogen. Yeah. Then PCOD, polycystic ovarian disease. You ask any female, young teenager, obese, so everybody knows about this polycystic ovarian disease, and so much is available in the net. So they would read and understand. So one among PCOD, especially what is called as Stien-Leventhal syndrome. I'm just telling you the components because this could be a 3-marker for you. So it is oligomenorrhea, anovulation, infertility, hirsutism. This is what bothers females. When we are obese, we don't like it. A lot of hair, hirsutism, no. And anovulation, it's a cause for concern. Mothers come and say, "Oh no, there's no regularity in the menstrual cycle and all that." So all these, oligomenorrhea, anovulation, infertility, hirsutism, obesity. So we should know these are components of polycystic ovarian disease or Stien-Leventhal syndrome. Young women and acne, say what? All these are unwanted for young women, but all these appear. See, obesity, hirsutism, acne, and all. And this is what we see. So why is it called as polycystic ovarian disease? So when we look at the ovary, lot of multiple cysts are there. See, look at these. You cannot put them under a neoplastic category. You cannot say it is mucinous cyst, adenoma, serous cyst, adenoma. They're all small cysts, up to about 2 centimeters in diameter. See, multiple cysts of varying sizes. And if we just look at a cross section of the ovary, this is how we see. So all these are follicle cysts. Look at the normal ovary here, cut open, and look at the polycystic ovary. So follicle cysts. So this is what you see grossly, routinely, not polycystic, but at least 1 or 2 cysts you keep on seeing as you are grossing the ovary specimens. What is this? This is first year MBBS histology. It's a Graafian follicle. Why do we say Graafian follicle? It's got a nice mature ovum there. And these are all follicles at different stages of maturity. Yeah. This is the stroma, ovarian stroma. Okay, but what has happened here? This is a wedge biopsy that is taken. Wedge biopsy for diagnosis of polycystic ovarian disease or Stien-Leventhal. So multiple follicles is where are all these situated? They're all in the cortex of the ovary. See, multiple follicle cysts and stromal hyperplasia. So this is what is seen in the ovary. So Stien-Leventhal syndrome, I've told you the components. Common endocrine pathology in reproductive age. Why is it called Stien-Leventhal? Where is everybody? So it is these two people who described it, okay, in 1935. So prevalence 5 to 15%. That's why we are so much concerned here. It's a multifactorial. This is now they say that it's hereditary basis. There are genes that are involved in various levels of steroidogenesis and androgenic pathways. So it is a hyperandrogenic state, all that we saw hirsutism and all that. With oligoanovulation, that means with anovulation is absence of ovulation, and oligo is infrequent ovulation, which does not occur regularly at 28 days cycle or period. So LH and estrogen are increased, luteinizing hormone and estrogen. FSH is decreased, androgen is increased, insulin is increased, there is insulin resistance. So you can read more about it from your gynecology textbooks. So you learn about more about the manifestations, the treatment aspect, everything. So only in brief, I have just told you the features of Stien-Leventhal syndrome. So coming back to cystoglandular hyperplasia, endometrial hyperplasia. So this endometrial hyperplasia, please recall what Dr. Disha has taught you, is divided into simple cystic hyperplasia. So we were calling this a cystoglandular hyperplasia past decade and all that, or from the time I started learning pathology. So now it's called a simple hyperplasia without atypia. So the terminology is making it very clear that there is no atypia, there is no malignancy. It is not becoming malignant also. Then second category is complex hyperplasia. So simple hyperplasia, complex hyperplasia. Complex hyperplasia is divided again into complex hyperplasia without atypia, complex hyperplasia with atypia. It's easy to remember. See, complex hyperplasia without atypia is referred also to as complex non-atypical hyperplasia. There are two double negatives, the double negatives that are used here. Non-atypical hyperplasia, whereas complex hyperplasia with atypia is complex atypical hyperplasia. Here we were calling these as adenomatous hyperplasia, and the terminology says adenomatous hyperplasia. That means more glands. So when more glands are there, what happens? When they want to, accommodate in that place, they're all arranged back to back. Okay. If this room can accommodate 50 students, if we put 75, what happens? They try to adjust. So students become compressed like that. So increase number of glands, they all get back to back arranged. So this is a very nice diagram here, diagrammatic representation. This is cystoglandular hyperplasia. Look at the glands of varying sizes. One is cystically dilated. So this is the second one, complex hyperplasia. So the glands are showing now branching and then they're dividing. Okay. But look at the nuclei. The nuclei are similar to this. But next is complex hyperplasia with atypia. So look at the nuclei. There's loss of polarity. They're hyperchromatic. They're all atypical. Okay. So this is what we spoke about the classification. This is the actual picture. Cystoglandular hyperplasia. Then this is complex hyperplasia without atypia. This is what I said, back-to-back arrangement. More glands are there, so they need to get accommodated in that space only. Then we see this. Then this is complex hyperplasia with atypia. Okay. So we are drawing a diagram of simple cystic hyperplasia without atypia. So what needs to be shown? Increased gland to stromal ratio. That means here there is proliferation of both stroma and glands, but still glands dominate. You can see, and endometrial glands are of varying sizes. Remember all this. This is what we are going to write. And many glands are cystically dilated and back-to-back arrangement only when there is a complex hyperplasia, and there may be areas of hemorrhage in the stroma, and stroma is dense and compact. So increased number of glands of varying sizes, many are cystically dilated, stroma is cellular, compact, dense. This is what is important for undergraduates, what they need to learn. But when we are reporting cystoglandular hyperplasia, we see a lot of other associated changes microscopically. So this is a simile. What is this? Cheese. Why Swiss cheese? I didn't find any difference in the cheese, Swiss cheese. Okay, so a lot of holes, the vacuoles, air spaces which are there. So they are likened to the cystically dilated glands here, and this dense stroma to the cheese, the solid part. Okay, so it is compared to cystoglandular hyperplasia microscopically. Even grossly, it was looking so spongy. See, that sponge, probably cystic spaces were seen. Okay. So this comparison simile is for cystoglandular hyperplasia. Okay. This is what we are going to draw now. So this is like writing along. So you're like writing with me. Yes. So let us start drawing the diagram. Hope it is visible. So we are writing endometrial glands here. Glands of varying sizes. So let us draw the outlines. Am I showing definitely variation in size of the glands? Yeah, very important is to write cystically dilated glands. So I've written one cystically dilated gland. Let me show another, only half of it. Okay? Let me show another cystic gland here. So what is the next feature? How are the cells lining the proliferative endometrium? There are tall columnar cells with elongated or oval nucleus, which is rich in chromatin. Okay, similar lining here, but pseudo stratified. So because it is proliferating. So let us start drawing the cells. So this is just a proliferative gland I have shown. You have already written this. So an elongated chromatin-rich nucleus, because it is busy dividing, we have to show some mitotic figures also. The lining, I think you can make out. And so you have just shifted to a cystically dilated gland. And how am I writing the cells? Again, tall columnar. We have to show stratification here also. So two rows probably. Okay, so if I write nuclei at varying levels that you can make further is stratification. So nucleus is not a dot here, please. So oval chromatin rich nucleus. So this is stratification. Normally what happens whenever there is a gland, whatever gland it be, when it gets cystically dilated, what happens to the lining epithelium? It gets compressed, right? So there may be only they start on treatment and secretion. So usually cystically dilated they have a flattened epithelium. So why am I telling you this is cystic atrophy? So another condition in endometrium where we see cystic glands is senile cystic atrophy. So there the glands appear cystic, but when we look at the lining, so they're all flattened. So here, cystically dilated glands, but at the same time, the glands are lined by proliferative stratified epithelium. Very important feature. So when you are looking at the slides, this is what has to be observed. So this tells us that the cells are proliferating. Okay. So when these cells are proliferating, definitely they are in mitosis. These are labile cells. So normally we see mitosis, but it's only abnormal mitosis that tells us about the malignant nature. See, epithelial cells are labile cells. So a lot of mitosis is seen, intestinal epithelium. the bile cells. They're all undergoing mitosis. So normally, typical it is bipolar mitosis. So all these glands, please fill them with the lining epithelium. So show this as stratified. So I'm also trying to fill it up. Otherwise, if I fill up only 2 or 3, then definitely follow me. Please don't do that. Okay. So this is glands of varying sizes, which are lined by tall columnar proliferating epithelium, stratified at many places or at many glands showing stratification and normal or typical mitosis also. Then second feature is about the stroma. So stroma, what is stroma made of? Short spindle shaped cells. Okay. So stroma is compact and dense. So this has to be filled with spindle cells, compact and dense. The stroma also is showing proliferation here. So why compact and dense? Yeah, it's only where in secretory phase that the stromal edema starts. So stromal changes are more in secretory phase. So in proliferative phase, we have shown you that stroma is dense compact. So here it is proliferating, so richly cellular, dense and compact. And there are other changes in the glandular epithelium, stroma and all that as our postgraduates should learn about. So I'll show you all that you've just joined. So Dallenbach is a very nice book that illustrates all that, and as we report these slides. So right, I'm not interested to show you spiral arterioles or anything. Only two features that you should know is dense and compact stroma. Can you feel it from that side? So it just saves time. That's all. You know, this is Dr. Nandini who is writing. Okay, she's just a new postgraduate. How is she writing? Students would be waiting. If you go to the class and do this, they throw chalk at you because they see your back. So blackboard teaching, this is one thing you should be visible to the students. Okay, at least slant way or be looking at the students. Whatever, even for this, they would have found some new or innovative method to distract or disturb the teachers. Okay, that should not be done. Okay. So this is the dense and compact. So endometrial glands of varying sizes. So this is cystically dilated gland. Okay. This is dense and compact stroma. Dense, compact stroma. Close the door. Dense, compact. So what is the name for this? Don't write CGH. So in Davangere, CGH means? Do you know? Okay. Because she's from Karnataka, she knows. CG hospital. Please don't write that. So write it as cystoglandular. No. What is the terminology? New terminology now we are doing. Simple hyperplasia. Yeah, simple hyperplasia without atypia. This is becoming doctor's handwriting. So all these areas, let us fill it up with the stromal cells. So simple, you can all, you can all. Okay. We are waiting for you to come back so that we can show you all these slides about cystoglandular hyperplasia. You've learned this. I think 40 minutes we've spoken about this. Just see the. Can we go back to the PPT? Just wait. Something special I told you today. So there are other people who are attending this class, not other people. So I consider them my as if they're my colleagues, students, so they're as good as my students also. Dr. Narayan Murthy, he is the head of the department of pathology in Chitradurga Basveshwara Medical College. And from the beginning, when they started their college, and we have been our department and their department, pathology, we're associated. We are doing a lot of teaching programs together. And today he said he wanted to put his students also to watch this class. I'm very happy to welcome your colleagues, students from the neighboring college also. It's a very short, small topic that I have taught you, and maybe another or one more class for practical topics related to female genital system and male genital system next week. And almost we have taught you all the diseases or the topics that are there in the syllabus, and maybe we need to start with the revision or that. Take home messages. The cystoglandular hyperplasia, now called as simple cystic hyperplasia. The features and how it differs from proliferative and secretory endometrium. So there should not be any confusion. All three slides are given to you for discussion. Of course, we give these slides along with history also. And what if this slide is given to you as with the history of infertility and another slide of secretory endometrium given with history of infertility? Okay, PGs can differentiate because secretory endometrium by history of infertility is endometrial curettage is done in the secretory phase or premenstrual phase for investigating a patient with infertility. So why infertility here? Because of anovulatory cycles. So that should be seen. And lastly, I'll just show you one or two slides that are there. This one. Okay. So this is the diagram that is there in your book. Ashmon, so that's why I've just taken because we're so much used to seeing these diagrams. This is the picture, Swiss cheese. So Swiss cheese, whenever you are eating cheese, okay, so please remember about this disease so that you will never forget. Not the disease, whatever you have learned today, you can recap all that. So that's about a simple topic that was taught to you today. And remember to breathe properly. Okay. So deep breathing exercises, do pranayama. So take care of yourself. Stay safe. Take care of your family. So enjoy learning. Okay. Learn something that is new every day, and learn something that is very important for leading your life. That's very, very important. Thank you. Don't waste your time, precious time, special time to be with your parents. So make use of it properly. Thank you. I thank students of Chitradurga Basveshwara Medical College and Narayan Murthy's students also for attending this. Thank you.